Welcome to the IRF and LTEC training for Section N, Medications, New Item, and Revisions. Here are the objectives for the session today. At the conclusion of this training, you should be able to describe the new assessment item in Section N, explain the definitions for the Section N items, and discuss the updates to the guidance for the Drug Regimen Review, DDR items N2001, N2003, and N2005. We will start by taking a closer look at the new assessment item in Section N. N0415, High-Risk Drug Classes, Use and Indication. Here is a screenshot of the new item in this section. For the IRF-PAI and LCDS, this data element will be collected on admission and discharge. The intent of this item is to record whether the patient is taking any medications in the specified drug classes and whether the indication was noted for taking the prescribed medications. The item rationale stems from the fact that we all know medications are an integral part of the care provided to patients. They are administered to try to achieve various outcomes, such as those listed here on the slide. However, patients taking medications in high-risk drug classes or categories are at high risk for side effects that can adversely affect their health, safety, and quality of life. So what do high-risk drug classes include? They include combination medications, which should be coded in all the categories and pharmacological classes that constitute the combination. For example, if the patient takes a single tablet that combines an antipsychotic and an antidepressant, then both antipsychotic and antidepressant categories should be coded. They also include medications administered by any route. You should include long-acting medications only if they are taken at admission and discharge. For this item, herbal and alternative medications are not included. These products are considered dietary supplements by the FDA. Now we will look at the item guidance for N0415. We start with the data sources one can use to complete this item. These might include the medical record, whether it be a paper or electronic health record from wherever the patient received their care that included treatments, programs, procedures, and medications. You can also include clinical communication or notes. These might be notes from the pharmacy, nursing staff, documentation from the physician or physician designee, and other clinical notes that might be applicable. You might also include recent documents, such as the patient's history and physical, a discharge summary, or any transfer documents. And the last data source would be any discussions with the hospital staff, as well as with the patient, their family, or caregivers. Here are the steps for assessment to complete the item, which are the same at admission and discharge. For column 1, using the data sources on the previous slide, you would determine if the patient is taking any prescribed medications in any of the drug classes. Next, if you check column 1, you need to determine the data from the data sources if there is a documented indication for all the checked medications. Now, let's go over some general coding tips. Be sure to code medications based on their therapeutic category or drug class, regardless of why the patient is taking it. For example, if a patient is taking an anti-anxiety medication for its hypnotic properties, you would still code it as an anti-anxiety medication. Remember to include medications only taken once during the assessment period, and do not code antiplatelet medications like extended release aspirin as anticoagulants. Patients taking oral anticoagulants that do not require lab testing should still be coded as anticoagulants. As we mentioned earlier, code dually classified medications in all the categories and classes regardless of how it is used. We provide an example here. Prochlorperazine is an antiemetic and an antipsychotic. It would be coded as an antipsychotic. Include medications by any route and administered in any setting. Be sure to include long-acting medications that are given weekly or monthly only if they are taken at admission or discharge. Transdermal patches deliver medication over 3 to 5 days and are considered long-acting medications. They should be counted if the patch is attached to the skin during the assessment period. Now we will review the definitions found in Section N. We begin with an adverse drug reaction, which is defined as any response to a drug that is considered unexpected, unintended, undesired, or excessive, and requires discontinuing the drug, therapeutic or diagnostic, changing the drug therapy, or modifying the dose. This does not include minor dose adjustments. Or it necessitates an admission to a hospital, prolongs a stay in a healthcare facility, or supportive treatment. And finally, one that significantly complicates the diagnosis, negatively affects the prognosis, or results in temporary or permanent harm, disability, or death. Most of you are familiar with drug regimen review. In post-acute care, the DRR is generally considered to include medication reconciliation, a review of all medications a patient is currently using, and review the drug regimen to identify and, if possible, prevent potentially clinically significant medication issues. The important note here is, unlike the new assessment item N0415, the DRR includes all medications prescribed and over the counter, including nutritional supplements, vitamins, and homeopathic and herbal products, administered by any route, for example, oral, topical, inhalant, injections, sublingual, parenteral, and by infusion. The DRR also includes total parenteral nutrition and oxygen. Clinically significant medication issue is a potential or actual issue that, in the clinician's professional judgment, warrants physician or physician designee communication and completion of prescribed recommended actions by midnight of the next calendar day at the latest. Any circumstance that does not require this immediate attention is not considered a potential or actually clinically significant medication issue for the purpose of the DRR items. Medication follow-up is the process of contacting a physician or physician designee to communicate the identified medication issue and addressing all physician or physician designee prescribed or recommended actions by midnight of the next calendar day at the latest. And what we mean by contact with physician or physician designee, this is all about the communication to the physician or physician designee to convey an identified potential or actually clinically significant medication issue, and a response from the physician or physician designee to convey prescribed or recommended actions in response to the medication issue. This communication can be in person, by telephone, voicemail, electronic means such as facsimile, or any other means that appropriately conveys the message of patient status. Communication can be directly to or from the physician or physician designee, or indirectly through physician's office staff on behalf of the physician or physician designee in accordance with the legal scope of practice. Now we are going to turn to a discussion of some updates to the guidance for the drug regimen review items N2001, N2003, and N2005. Here is an overview of the revisions. For N2001 drug regimen review, we have expanded steps for assessment, revisions to the coding instructions. For N2003 medication follow-up, we have some revisions to the item rationale and coding instructions. And finally, for N2005 medication intervention, we have revisions to the item rationale and steps for assessment. We will start with the expanded steps for assessment for N2001. An additional step 4 was added to further clarify what is meant by a potential or actual clinically significant medication issue. For example, a patient taking an excessive as well as an inadequate dose of medication. Medication therapy that is ineffective, such as analgesic, which is not reducing or controlling pain adequately. Here are some more examples of potential or actual clinically significant medication issues. For example, the medications missing from the prescribed regimen. A reminder, circumstances must require immediate attention to be considered. There have been some minor revisions to the coding instructions. The instructions for Code 0 reinforce the need for the clinician to use professional judgment to identify a potential or actual clinically significant medication issue. The changes are highlighted here in blue text. The instructions for Code 1 also reinforce the need for the clinician to use professional judgment to identify a potential or actual clinically significant medication issue. We provide an example on the next slide. If patient medications are ineffective for the diagnosis or symptoms for which they are prescribed, the clinician could determine if there is a potential or actually clinically significant medication issue. Code 9 is the patient is not taking any medications. Guidance has been clarified to include medications by any route, as noted by the blue text. The coding language has been expanded from just the clinician to include facility that can determine whether there are potential or actual clinically significant medication issues. Let's look at N2003 now. Once again, note the changes highlighted in the blue text. We see the rationale has been updated to include facility. Physician or physician designee prescribed or recommended actions in response to identify potential or actual clinically significant medication issues must be completed by the facility by midnight of the next calendar day at the latest to reduce patient harm. According to the steps for assessment, N for N2003 should be completed if the answer to N2001 is equal to 1. Again, two-way communication is now just the clinician, but expanded to facility. All actions prescribed or recommended by the physician or the physician designee were completed by midnight of the next calendar day. Now we'll take a look at the coding instructions for N2003. For code 0, the instructions now read, if the facility did not contact the physician and complete the prescribed or recommended actions in response to each potential or actual clinically significant medication issue by midnight of the next calendar day. And for code 1, yes, if the facility contacted the physician and completed the prescribed or recommended actions by midnight of the next calendar day after each potential or actual clinically significant medication issue was identified. Now we turn to the updates for N2005. The item rationale for N2005 has been revised. It now says, physician or physician designee prescribed or recommended actions in response to identified potential or actual clinically significant medication issues must be completed by the facility by midnight of the next calendar day at the latest to reduce patient harm. The guidance highlighted in pink on the slide has been removed. In the steps for assessment, the time points for completion of N2005 are clearly defined. The steps for assessment have been revised and updated to be consistent with the other DRR items. Using the clarified criteria, you will determine whether any potential or actually clinically significant medication issues were identified upon admission or at any time during the patient's stay, admission through discharge. As with the other items, the two-way communication is between the facility and the physician or their designee. All actions prescribed or recommended by the physician or their designee were completed by midnight of the next calendar day. There are some revised coding tips for N2005 Just another reminder, all references to clinician have been expanded and changed to facility. If the prescribed or recommended action will take longer than midnight of the next calendar day to complete, code 1, yes, should still be entered. If by midnight of the next calendar day, the facility has taken whatever actions are possible to comply with the recommended action. Today, you learned about the new assessment item in IRF and LTEC for Section N0415, high-risk drug classes use and indication. We also reviewed the definitions found in Section N. And finally, we discussed the updates and revisions to clarify or enhance the guidance for the DRR items N2001, N2003, and N2005. We welcome questions, and if you would like to submit questions you have about this presentation, please send them to pactraining@econometricainc.com by May 15th, 2022. All questions submitted will be reviewed, and those that are most common will be included in a Q&A document published after the virtual event. We invite you to attend the practice coding workshop that will be held in June. Based on the review of questions submitted, select questions will also be discussed in a Q&A session during the June 2022 virtual live event. Thank you.